Hello, everyone. Welcome to this webinar today on mindfulness in practice. My name is Dr. Ben Buchanan. I'm the co-founder and CEO of NovoPsych, which I think some of you will already be using. And we're joined today by Dr. Bruno Cayoun, who is an expert in mindfulness and also the producer of two wonderful psychometric scales that we're going to be talking about today. So without further ado, I'd like to introduce Dr. Bruno Cayoun, who is an expert in mindfulness and also a developer of these wonderful scales. Dr. Bruno Cayoun is a clinical and research psychologist and the developer of mindfulness-integrated cognitive behavior therapy. He's the founder of the Mindfulness-Integrated Cognitive Behavior Therapy Institute and a leader in providing professional development and mental health services since 2003. As well as doing all of that, he also has a private practice in Hobart, Australia, and undertakes research and publishes research based on mindfulness. He's the author of Mindfulness-Integrated CBT Principles and Practice in 2011, and also Mindfulness-Integrated CBT and Wellbeing for Personal Growth in 2015. So it is my pleasure today to introduce Dr. Bruno Cayoun, who has a very exciting webinar for us today. Welcome, Bruno.
Thank you, Ben, for this nice introduction. And I am very pleased to have been invited for this purpose. I think it's a very nice opportunity for so many people to not only discover the scales, but also hear a little bit about how mindfulness can be integrated in CBT, although that won't be the main focus today. So thank you for this invitation. So we will be looking at measuring patient progress during mindfulness-integrated CBT, but not in particular Mrcbt, also across various mindfulness-based intervention, or MBIs, as we call them. And hello to all my colleagues and friends who may be there as well. During this webinar, I will introduce very briefly mindfulness practice for those who are not familiar with it, a rationale for introducing or integrating perhaps mindfulness in therapy. And this is based on the co-emergence model of reinforcement in Mrcbt. So those who are very familiar with it, might be a nice revision. 4-stage program of Mrcbt. All this is to bring us slowly towards the rationale for measuring it with these two scales. So the expected changes in the brain with Mrcbt, although again, I won't go overboard with a 45-minute long seminar. We could stay there for days on this. Difficulties in measuring mindfulness, which is really the crux of why we're here, and the mindfulness-based self-efficacy scale, how it may address that to some extent, and certainly the advantages of using the Equanimity Scale as well. So what is mindfulness? Well, it's definitely more than just paying attention in the present moment. That we know and we can be sure of. And it is definitely not paddling on a board or relaxing as you can see it here. It is certainly not equal to mindlessness or the opposite of mindlessness. So the lack of mindfulness does not mean being inattentive only, and I will discuss this a little bit. So briefly, in terms of historical background, mindfulness training was not born in the 70s or 80s in the US. It was developed in northern India 26 centuries ago by someone known as the Buddha, but many still don't know that. And it was used for the purpose of integrating real life matters, natural laws, into decisions and actions in our everyday life, including the notion of impermanence. So, and especially so. So the anecdotal evidence, reading the literature of the time, reveals some very long-term changes in personality, and not only reported in Eastern literature, but also more recently in a whole book published by Richard Davidson and colleagues, which really demonstrate changes in personality with mindfulness meditation. So, what is mindfulness? There are different definitions. Here, it is a nice and comprehensive way of understanding in terms of an intentional experiential awareness, so it has to be your own experience, in the present moment, and free from reactivity and identification with the experience. Those two bits are very important for us in terms of measurements. So it is and has been for 26 centuries a means to an end. We don't meditate and be mindful for the purpose of being mindful. It's much more fun not to be so. Being mindful can be hard work when you're not used to it. And it is used as a tool of investigation to develop a better ability to observe reality of that present moment with more wisdom, with more objectivity. So in terms of process or practice, we develop first the ability to sustain attention, and usually at the entrance of the nostrils, for reasons we don't have much time to discuss here today. But basically, it's easier to do, and breath is always with you. And we learn to also not identify with whatever thoughts and experiences in the body that we may experience in the present moment as we sustain attention. Not identifying with the experience, very important, but not to do so requires a certain attitude, a certain ability, because we are so conditioned to react to unpleasant or pleasant sensations. Similarly with positive and negative thinking, that unless we have a specific attitude, being aware of these on its own is certainly insufficient. We are conditioned to react. So we need equanimity in order to prevent reactivity, which is the learned or conditioned response to whatever arises in the present moment as we are learning to be aware of it. So equanimity in the Webster Dictionary has been described quite accurately, actually. This is 1913 version, but still quite on the spot, on the money. Equanimity as the evenness of mind, that calm temper and firmness of mind, which is not easily elated or depressed. It also means patience, tolerance, calmness, composure, an equilibrium state in some form. And being equanimous simply is the adjective. So basically, in terms of mechanism of action, it's very important we understand that when we try to measure it. So awareness and equanimity are considered core mechanisms, both from the traditional literature and modern, understandable, readable, verifiable scientific writings. Equanimity in the context of mindfulness, rather than just a definition in a dictionary, has been defined as the ability to see without being caught by what we see, and more specifically, the ability to remain unperturbed by an event experience within the framework of one's own body and mind or thoughts as a result of objective observation, without personal biases. Therefore, equanimity relies on awareness of one's own thoughts and physical sensations. Question always is, do we need to meditate? There are different authors and teachers who will say, oh, you don't need to meditate, you just be aware, just know what you're doing, and be rational about it, perhaps. However, if you try to incorporate, I don't know if you have an old computer still, but if you try to incorporate a very complex and new software with hardware, you're going to have problems, yeah? You have to update hardware all the time as new software, new apps are being developed. Similarly, we try to integrate something quite radically different in terms of how we address our daily life, internally and externally, with the same brain, that doesn't work very well. It doesn't stick. So if we try to be serious about practicing mindfulness training, then we have to do so in a way that produces neuroplasticity. So the repeated practice of mindfulness produces changes in the brain, which I will briefly mention only today. The practice is also necessary for really behavior change that will stick over time. There can be an experiential acceptance only when there is an experiential exposure. In other words, you can't really learn with mindfulness training to be accepting of a situation or an experience that you have in the present moment without being exposed to it, right? So it is very important that we understand mindfulness training in terms of exposure, and therefore that we measure so when we want to measure progress. So mindfulness also relies on interoceptive desensitization. And it's not simply a top-down or cognitive processing approach. We need to learn to feel sensations in the body because that is what we react to, as I will explain in a few moments. So how do we operationalize this? So first we need to concentrate on breathing to regulate attention. Every time a thought arises, as I sustain attention in the present moment, holding in mind the task, so working memory is involved, sustained attention is involved. The second executive function is to inhibit the response to learned response to whatever stimuli arise, such as a thought or sensation in the body. So we learn to regulate attention also through the third executive function by switching attention back to the entrance of the nostrils. So sustained attention, response inhibition, and attention shifting constitute very important prefrontal cortex and anterior cingulate cortex executive function related skills, which, by the way, are impaired in ADHD and many other conditions. And we need to systematically scan the body or survey the body to develop equanimity and not just an awareness of sensations in body, because one can become more aware of sensations. Without equanimity, it's a catastrophe. They start to react all over the place and they drop out very quickly from the practice. And even some will report some detrimental effect of mindfulness because they haven't been taught about equanimity. That is very central to a serious practice. Yeah. So it requires or constitute a generalized interoceptive exposure and desensitization for those who are familiar with behavioral formulations. So we are exposed to sensations in the body, interoception, and desensitize the response by remaining equanimous. And of course, it requires a fair bit of inhibitory control to prevent our learned habit. The learned habit of dealing with unpleasant experiences is usually avoidance. So general aims of mindfulness practice are to develop greater self-awareness, of course, objectivity, and acceptance and detachment with each experience, rather than just being mindful. So what is the theoretical framework or the mechanism involved in that, for MICBT at least? And many methods don't have a strongly grounded theoretical framework. So when there is a stimulus, we encounter a situation in life, typically we sense it, we know it because we see it, we taste it, we hear it, etc. We touch it, and we can feel it if it's internal. If it's internal in terms of thoughts, then we know we have a thought. So this is sensory perception. And then we make sense of it. This is largely automatic. We have learned throughout life to evaluate stimuli, and we're very well conditioned to make judgments as to something is agreeable, disagreeable, pleasant, unpleasant, good, bad, etc. This is very wired in the brain. So there are things that are important to us and things that are not so important to us. Yeah, so what is propositional, for instance, is that there is a MAAS computer mouse on my desk. Well, I'm not going to have panic symptoms over that because it's put in a different way. I don't have OCD either. So this is more propositional. Or who's the prime minister of your country? This is proposition. However, it becomes implicational in terms of personal values. If the prime minister or president of your country is someone you really dislike, so suddenly, because of this, as soon as we take something personally, so to speak, a co-emerging sensation arises in the body. And you will know that with your clients, your patients, with yourself, that simultaneously, as soon as you have a negative thought, to put it simply, you also have an unpleasant sensation in the body. And it's the same in reverse with positive thinking. You have a pleasant sensation in the body. And the response to that follows the co-emerging body sensation rather than the stimulus. So we react because of what we feel and not because of the trigger. Very, very important conceptualization in MICBT. Therefore, doing exposure during therapy to the interoceptive feedback or the sensation in the body is crucial for desensitization, rather than just doing exposure to the stimulus, a spider or whatever else that one may be phobic about. And of course, the reaction becomes the input for sensory perception, and we end up within a feedback loop, as in, for example, ruminative thinking and so forth. So this is a normal way of processing information, but information can be trained to become in disequilibrium state. In this case here, in the normal way of processing information, craving and aversion, which are the typical reactions to pleasant and unpleasant sensations, act as reinforcer, because if we succeed at avoiding an unpleasant experience, then we are reinforced over time. If we succeed at being attached and craving, receiving more pleasant sensations through our reaction, or at least a relief from the unpleasant sensation, then we are reinforced over time. So reward, as in positive reinforcement, negative reinforcement, depend on how we respond to co-emerging body sensations after an evaluation. And the four components work very well in equilibrium state, but as soon as we get stressed, a disequilibrium state takes place. And here we have a disequilibrium state in relation to their brain correlates. Again, I don't want to go too far into this because of the limited scope of this seminar or webinar. But when we are in a stressed environment or stressed state, we basically have less access to sensory perception, our objectivity of what the stimulus is, or almost objectivity, you may say. And therefore, also, because these are similar systems of sensory perception, less access to feeling whatever we feel in the body. And with exaggerated states of, say, anxiety, people tend to dissociate. And this is a typical example here. So this is because attention is reallocated to judging and reacting. So it's very efficient when you're chased by a lion. You don't need to go into very complex analysis of how you feel in the body. You just run for your life. Yeah. So you judge, we judge, and we have an ability to say, well, that looks like I'm going to die soon, whether this is true or not, and we run for our life. Similarly, when we have small day-to-day stressors, we also tend to favor judgment and the meaning of what the stimulus is according to our conditioned habit, and we tend to react without really feeling what we feel in the body. So the disequilibrium state has been demonstrated to be significantly related to disorders. The more stable and established is a disequilibrium state, and the more chronic is the condition. And here are some of the studies that demonstrate that disequilibrium state is associated with psychopathology. So I won't go into each of these studies, but you will have an available copy PDF copy of those slides. And I think Ben has made them available to you, so you'll be able to look into this a bit more closely if you wish. So that constitutes a rationale for mindfulness-integrated CBT. A system in equilibrium resists psychopathology, and you will know that more healthy and relaxed individuals tend to feel more subtle sensations in the body, and earlier in the sequence before distress becomes unmanageable, and have a greater ability to know their thoughts. And you see that with your own patients, your own clients. There is strong evidence that daily practice in mindfulness meditation transforms this ability through neuroplasticity, and these changes in the brain facilitate the transfer of skills in our daily life. So we recreate an equilibrium state through stage 1 of MICBT, and we do so through mindfulness meditation, mindfulness of breath, which, of course, as I said earlier, helps reduce the tendency to not be aware of our thoughts. And when we become more aware of our thoughts, we have an ability to, or a choice, to not take things so personally, understanding this is just thinking, this is just a thought. Yeah, so it takes a bit of training, as you all know, or at least over 80% of you do know since you practice. And the systematic body scanning also helps develop an interoceptive awareness and acceptance, as in equanimity. So this interoceptive awareness and acceptance recreate the equilibrium state we are looking for, which I briefly mentioned in the model, the co-emergence model earlier. We also use, at least in MICBT, we don't throw the baby out with the bathwater. We use a Socratic dialogue to challenge resistance, in particular, to practice. As many of you would know, not all your clients are willing to get up in the morning every day and meditate. So we use this as part of the tools in therapy, and also self-defeating thoughts that they may not be able to practice, or they can't overcome the pain in their back when they sit up straight, or deal with difficult thoughts when they have them. And we encourage the practice, partly using this ability, this dialogue. And essentially, we're looking at recreating an equilibrium state so that our clients are no longer overly judgmental and overly reactive. And that is transdiagnostic. We try to recreate a balance and stability across those 4 mental characteristics on the basis that personality relies on brain connectivity that maintain this equilibrium state over time. Now, if you look at the most profound nature of and mechanism of personality factors and chronicity or chronic conditions, they are brain related. Ultimately, if they are not due to an unfortunate inheritance of bad genes, they become so due to learning. So learning effect produce brain changes over time. And that little tiny brain, as it grows up with those networks wired in a way that may well be, as you see it on the screen, over-judgmentality, over-reactivity, and then we call it a personality disorder. Okay, so this re-establishment of equilibrium state is transdiagnostic. As you may already guess, if you're not aware of this model, that whether one has this disorder or another, or no disorders, just being a bit wired and tending to be stressed, recreating an equilibrium state in the nervous system applies to all. So as we become less judgmental and reactive, we can reallocate attention to being more perceptual, more objective with the stimulus, and of course more aware of early cues of distress when we make a judgment, and deal with the early cues of distress when they are still manageable, not too late when it becomes an unmanageable emotion. And the main aim is explained to clients in terms of a recalibration of the nervous system rather than being overly pathological. So in MICBT, we have 4 stages. In the first, and again, I fly through this very quickly. In the first stage, we begin to recreate an equilibrium state among these mechanisms to process information in a more balanced and helpful way. And that doesn't take that long, usually 4 to 6 sessions. That depends on the client as well, the client's severity. And then we invest those skills of awareness and equanimity in the second stage of MICBT, which then introduces exposure to situational avoidance. And that could be just about any avoidance type, except interpersonal conflict, which we deal with in stage 3. So in stage 3, we invest the ability to self-regulate and the ability to do so while doing exposure to situations we avoid in situations of conflict and tension. We also learn to be more assertive and confident and kindly assertive, of course, in stage 3. And all these 3 stages are then invested in the 4th, the empathic stage at the end, to prevent relapse. So here people learn compassion for themselves and others, and learn about ethics, how compassion requires ethical behavior. Compassion without ethics doesn't make any sense. Yeah. If we keep on harming ourselves while trying to be compassionate with ourselves, it won't go together very well. So here are the 4 stages of MICBT, really briefly mentioned. And MICBT, compared to treatment as usual, has been shown to be quite effective across a wide range of situations. Here, these are a few, but they are sufficient to give you an idea of transdiagnostic efficacy. If you wish to have a look at least at some are open access, some of these studies, some are not. So if you wish to look at the abstracts or the papers that you can download, you can simply look at our website research page on the MRCBT Institute website and have a look at these. This is quite a range, including neuroplasticity in perinatal depression, where researchers clearly demonstrated a different genetic expression, gene expression in those women. But there are difficulties in measuring mindfulness. How does one measure mindfulness? And on what ground? So I will do my best to explain this briefly, but efficiently. First, we have a problem with construct validity. And those who use mindfulness scales already would have noticed that, according to your practice, how do those items on certain scales compare to what you are teaching your client? For example, if you're not aware that if your client is not aware today that they are eating a sandwich and they realize they finished the whole thing before they realized they were eating it, or partly realizing that they did so, how does that constitute what you're trying to teach them? So being present, being aware of the present moment, of course, requires attention. But as I said earlier, this is insufficient to qualify for mindfulness training. So items are often more related to attentiveness, or with the MAAS, for example, inattentiveness. And inattentiveness is not a lack of mindfulness. We can be inattentive for so many reasons. At least trait mindfulness. So being inattentive at a given moment does not reflect trait, as I said, mindfulness. Perhaps state, but not trait. So lack of equanimity items also, despite its central role in mindfulness practice, is a real letdown. Yeah. So if we don't have equanimity items in a scale, we cannot really measure mindfulness as it is supposed to function. Just a very brief example of a situation with the FFMQ. In fact, it was called differently before. So this, but basically the FFMQ is the 5-factor mindfulness questionnaire, which is one of the most used questionnaire, if you don't mind the 34, I think, items. Until 2004, it was called a different scale, and it was a bit more limited. And at a conference, people I know, and some of whom are colleagues, mentioned to the author, the main developer, Ruth Bayer, how come you don't have non-reactivity items in your scale? If it measures mindfulness, you really should have a 5th dimension. At the time, there were 4 subscales. And this is, otherwise, this is not going to work. So Ruth Bayer did a large study, a study of studies, a study of other scales, and reconfigured a new questionnaire, which she called then the 5-factor mindfulness questionnaire, which was published in 2006, which was much, much, much better, much more comprehensive. And it included, interestingly, a non-reactive or non-reactivity, non-react, it's called, subscale, which makes complete sense. That was a nice reflection of an understanding of that importance. So comparing meditators and non-meditators is another problem with mindfulness scales. Because how can we really know how to be mindful without being mindful about not being mindful? Yeah? So if you ask your client who never practiced mindfulness, who's quite distressed, etc., you give them a mindfulness questionnaire, a mindfulness that measures mindfulness, I mean, yeah, mindfulness skills. How do you think it's going to be easy for that person to self-assess fairly objectively? So the only way you're going to have to do this is by asking them at the end, how do you now know, or do you now think that you were mindful at the start? Then yes, if you use a post and pre-assessment, you may overcome that problem. But these questionnaires are not geared for that, unfortunately. I think we're probably the only ones in our team that promote this. But unless you do that, you end up with a lot of biases. And here's a typical, very gross bias here from Paul Grossman and Nicholas Van Damme, a beautiful study published 11 years ago, which measured basically the difference on the FMI, the Fribourg Mindfulness Inventory, which in my view is actually pretty good. Yeah, much better than many. It was based on Vipassana meditators, and assessed by Vipassana assistant teachers, so very well informed. But what happened was that they gave the scale to long-term meditators, to binge drinking students, and to students who were not binge drinking. And look what you see here on that graph is incredibly revealing. The long-term meditators scored the least on that mindfulness questionnaire, which I repeat is a good one. Oh, well, on the whole, with whatever you can get out of a mindfulness questionnaire is pretty good. And normal students, and all these were statistically significant differences. So the binge drinker students rated themselves as being the most mindful. Again, significant differences here we're talking about. More mindful than both other groups. And the non-drinking students were rating themselves as being significantly more mindful than the long-term meditator students. Why? Because when you meditate, you know when you're not mindful. Well, the more you meditate, the more you know, put it this way. So we have a problem, don't we? And the third difficulty is comparing between meditators. So between meditators too. Why? Because different meditators have been trained by different teachers who come from a different lineage. For example, the Mahasi Sayadaw method of meditation is quite different to the Goenka and Ledi Sayadaw, that's my lineage of Vipassana meditation. So we will focus on measuring things differently according to what we believe is the is the skill of choice. And then you end up with the more modern diluted approaches like MBSR, MBCT, which are, more geared towards addressing, people in the West and people with clinical issues. So you have a lot of varieties of approaches. And if even when you compare between them, using simply mindfulness questionnaires is going to be including some important variability. So what's the solution? Well, the solution that we found was to not measure mindfulness directly, but mindfulness in terms of its effects. So it was developed to overcome these limitations, at least in part. The MAAS, and I will call it this way from now on, the MAAS was designed to measure self-efficacy in overcoming stressors in daily life as a consequence of mindfulness training during and after MICBT and other mindfulness programs. Many are using it for other programs like MBSR, for example. And it was developed to measure people's confidence in achieving the original purpose of mindfulness, which is to reduce suffering, not to become more mindful. Why would you be interested in that? So, especially in clinical practice, we want to measure reduced suffering to make sense of our work with the client. So, in terms of the characteristics, again, I will be quite brief because we would like to leave some questions at the end. Time for questions. It is a 22-item self-report questionnaire that people self-implement. So it's a self-report. And that can be used by adolescents. I mean, we see younger adolescents, and we suggest down to 16 years of age. But clever teenagers can do it even if they're a little bit younger. And we see studies of people at school in different countries who do it with, middle adolescents, and they get valid results. It contains six subscales: emotion regulation, social skills, equanimity, of course, has to be there, distress tolerance, the ability to take responsibility for what one feels in particular and what others feel. In other words, not taking responsibility for what others feel, and the ability to be effective with others, interpersonal effectiveness. And you have huge norms comparison. We collected data since 2009. And we're still collecting data. There's over 12,000 people in the norms, but a good chunk of them cannot be used for norms because they are mixed norms. So for proper norms, we have over 7,400 something entries. So the norms are quite reliable and across countries. So in terms of the availability, so you can have the pen and paper, which you can find on the MICBT website. Go to tools, research tools, for example, and you have it here on the left, and you have the questions. So again, on your PDF, you'll be able to look at these questions if you like on that slide. And on the right side, you have a nice attempt from someone who did it electronically on the Novopsych website. So I like this because it provides normative percentile scores. So these are, in my mind, the most talkative, the most revealing in terms of how we compare our clients with the majority. Yeah. So these are community norms. So these are about 4,000 people here. So every time you compare the scores of your clients, it's compared with 4,000 people. And that's in the English-speaking countries. So quite efficient, and you can see the 4 subscales being measured here. In terms of psychometric, again, very limited time, so I won't linger there. But since 2012, the first EFA, or Exploratory Factor Analysis and Validity Study, that was one of my students, actually, there's been loads of studies done across a wide range of samples in Australia and elsewhere. And the most recent confirmatory factor analysis comprised 2 Australian samples, so large samples of almost 1,400 people in the clinical group and almost, well, 2,800 in the community group, 2 Canadian samples, almost 600 in the clinical group and over 300 in the community group, and 1 Australian sample of students. The overall reliability is good. As you can see, if you're familiar with this, I know that not every one of you here is a statistician or a psychometrician, so I won't bombard you with numbers, but basically 0.89 is good for reliability or internal consistency, the overall. Some scales you will notice in the website there when you visit it for your own interest. Some subscales have lower internal consistency because there are only 3 items per subscale. So that is known to reduce the correlation, but otherwise it's still very efficient to look at the subscales. And I have some studies in mind here where, in particular, one randomized controlled trial we did with my colleague and friend, Sally Francis, and others, demonstrated that the most important mediating variable for that randomized trial across a wide range of disorder for Mrcbt was indeed equanimity. And test-retest reliability was good over 2 weeks. So 0.88 is good enough, definitely. So there's good validity also, which means high correlations with mindfulness scales and construct-related measures, and negative correlation with the DAS in particular. So depression, anxiety, and stress scale. You can see this paper published in Mindfulness. You can download this. You can also look at our website for papers, as I mentioned earlier. So in terms of the Equanimity Scale, which is much newer, we did 3 studies over the last 2.5 years. So that's actually much more, over the last 4 years, but published over the last 2 years. It was developed to specifically measure core mechanisms of change in mindfulness. As I said earlier, we don't have equanimity subscales in most mindfulness measures. So it measures specifically trait equanimity and its effects in overcoming daily stressors, and not just through mindfulness meditation, but you can use this scale even if you don't use a mindfulness-related therapy approach. Yeah. So even with CBT, you'll see whether there's a small effect of improved equanimity. It's possible. Yeah, we haven't tried, actually. That would be good for someone to do a study on this. I'd be very interested. So it was also for the purpose of developing a measure of experiential acceptance and a reduction of daily reactivity, emotional reactivity in particular. So in terms of development and characteristics, we identified, that's how we went about it. We looked at a large number of mindfulness questionnaires and related measures. So 26 of them, and we identified 517 items within those 26 questionnaires. Of these items, we did an assessment across a number of us who are experienced with, quite a lot of experience with mindfulness practice. Personally, I have practiced for 33 years and taught for at least 19 or 20 years. So, and my colleagues have quite a large experience as well. So we were quite confident that 42 items of these 517 were endorsed accurately as being sufficiently associated with equanimity. And after the first study, we identified 16 items to construct the the Equanimity Scale. Hence the name, Equanimity Scale 16. Not to confuse it with a French one that has much more items and measures it quite differently. So those are the only two questionnaires, by the way, that currently exist on equanimity. It contains two subscales. One is exactly as the theoretical framework suggests, experiential acceptance and non-reactivity. And we have current norms for 517 entries or people. So in terms of development, okay, hang on, this is a repetition. Here we are. This is the pen and paper version that you can download again from the website. And on the right side, you have the NovoPsych results display, which is, it's just a graph here, which is quite similar in terms of information you get from the MAAS. So typically, NovoPsych likes to display this kind of format, which I like very much. You have normative, percentile, and the score. And of course, you get a progress over time, which is a line graph over time, which is quite handy. So in terms of, I think my slides are a little bit, you have the wrong title here. It should be the Equanimity Scale, my apology. We have good psychometric properties in 3 Australian studies. That includes exploratory factor analysis, confirmatory factor analysis, and a post and pre-assessment, which is quite interesting. As I mentioned earlier, when you ask people retrospectively, how do they now think that they were at the start of therapy, how equanimous they were, then we can see a huge shift, which means it's actually good news. When you measure it, it means that people have shifted their ability to reassess themselves due to increased self-awareness. So we have, again, a similar reliability factor here, an overall alpha of 0.88, and test reliability, this time over 2 to 6 weeks of 0.87, which is good as well. There's also good validity across similar measures, so a positive correlation with mindfulness-related constructs and negative correlation with the DAS. And it's also good in terms of measuring progress in therapy, so sensitivity to change. And that was our third study with the post and pre-assessment, which is now being in press for publication. So you can see very clearly how equanimity progresses over time as you implement therapy. And this is the paper which shows the first psychometric analysis. So this is in case some of you may be interested in looking further into Mrcbt, both as a training or in terms of what it offers as information. As you can see here in the research section, or if you go to the menu for research up the top, you can see research tools, and then you will see these 2 scales as well, where you can download the pen and paper, and there's a lot of information on it. But basically, if you already work with NovoPsych, or you have not used NovoPsych as a means of measurement for your work, well, I use it all the time, thank goodness. It's there, there's loads of, I'm not here to promote neuropsych in particular, but I really like the system, and I'm really grateful to Ben for having constructed this over 10 years ago. So you can just go to NovoPsych, get the tools, select the tools, those 2 scales, and off you go, have instant results as well. That's really good. So that's about it for me in terms of the presentation. And I'm very open to any question you may have.
Well, thank you, Bruno. That was really interesting. I mean, the most interesting part for me was when you said, how are you supposed to ask someone if they're mindful or not, if they're not mindful about being mindful, which is, totally true. I mean, if you're not mindful, you won't know that you're not mindful. So we've had lots of people asking questions during the session, and I'd also really strongly encourage you to self-administer those questionnaires. So logging into NovoPsych, self-administering the mindfulness-based self-efficacy scale and the equanimity scale, just to see where you sit in comparison to the normative data that Bruno has compiled. I always find that really interesting. And if you gain insight into yourself through self-administering it, you can imagine the sort of insights that clients will gain through having an objective assessment as well. So Bruno, a couple of questions that came up from our audience. Someone, Claudia asks, I have a few adult clients with ADHD. What is your advice in tailoring mindfulness training to this population, such as do's and don'ts?
With ADHD, that was my doctoral research, so I'm quite familiar with it. With ADHD, no one could supervise me in mindfulness in those days, so I chose mindlessness. I chose the absolute opposite. Not quite mindlessness, but diametrically opposite matters. And I learned much more than if I had studied mindfulness, I believe, because I understood how the brain attends and doesn't attend, for instance. So with ADHD, you have the impairment of these three very executive functions we are trying to teach people with mindfulness. So they're going to struggle. And yet this is what they need most. So that's the irony of it. So therefore, mindfulness training is wonderful for ADHD, but you need to use a very slow and systematic shaping approach. So we use breath counting to first shape attention. And look, if you're interested in a protocol for implementing this, if you're a clinician and you already use mindfulness in particular, I'm happy to send or to post somewhere a protocol for delivering it to ADHD, especially kids. But we use basically an approach that enables the person, and we can teach this to seven-year-old with ADHD, 7-year-old kids, breath counting. So and there's a whole shaping process. I won't go into this, but basically don't start with very standard mindfulness practice. So teach, perhaps if they are children in particular, to have a way of, say, counting 10 breaths accurately, closed eyes. And if they are successful, plus minus one, then reward them, praise them, etc. And at home, for a week or two, they learn to count and increase the count of breath, etc., etc. So that they are at least paying attention. Through accuracy of counting that they are paying attention to their breath, and slowly shaping the mind to be attentive, closed eyes, then we can introduce mindfulness practice. So first 2 minutes, then 5 minutes, then a bit more. Before they get bored, they need to get results. So there is a protocol. So please let us know. I'm not sure, Ben, how that could work.
I can send everyone. I'll send everyone a recording of this who registered, and I can include that protocol. On your response about ADHD, I like what you said. People need to get results before they get bored.
Oh yes, otherwise
that's the key, isn't it? I think you've already answered this question from Stella. Stella asks, is equanimity the same as experiential acceptance as used in ACT? And that is exactly one of the subscales in
experiential acceptance doesn't mean non-reactivity, but it's certainly a very important part of equanimity, definitely. However, just an add-on to this, you cannot accept what you're not aware of. Yep. So experiential acceptance is good in theory, but it's very difficult to do with the early onset of an emotion. You can only accept what you become aware of. If you're not practicing neuroplasticity, your threshold of awareness remains high, and whatever is reactive beneath that threshold, you can't accept it. It's still going to react. This is why mindfulness meditation is important in terms of producing neuroplasticity, which decreases your threshold of awareness, and you become aware of more subtle and earlier cues of distress. When these are accepted, then there's no need to react. Even if you become more self-aware, at some point, you become only aware of the emotion when it's strong enough, often difficult to manage, and experiential acceptance is hard to come by at that point, depending on the severity of the person's condition.
Yeah.
So my short answer is meditate. Don't just don't just say to someone, just accept your experience. Yeah, right. It's good in theory, but the brain is conditioned and wired in a certain way. But certainly, in terms of the answer, the short answer is yes, this is part of equanimity.
So I've got a question for you. I think 2 weeks ago, there was a very large study published on mindfulness in schools, where they evaluated how effectiveness a school-wide mindfulness intervention is, and it was found to be not effective at reducing psychological distress or the onset of psychological disorders at all. Why is that?
What mindfulness method was that?
Well, it was that the teachers went to a day-long mindfulness training.
Oh,
and then the teachers,
it's a catastrophe already, I can tell you.
And then the teachers rolled it out. So, I mean, that's the answer there. But
okay, you know, this is attention training. This has nothing to do with mindfulness. On the basis, oh, well, I don't know enough the procedure they use, to be fair. But you cannot do a one-day training or 5-day for that matter in mindfulness and without practicing it yourself and developing the experiential skills to understand experientially what it's supposed to be, and teach this to kids who have no idea. So look, we have to be realistic. Mindfulness is an umbrella term to begin with, and on top of it, it's an industry. And you know, unless you have skillful trainers who teach skillful students, who teach skillful participants, it's not going to cut it. Yeah. There's no way. This is part of why. So, you know, I'm a researcher, so I look a lot at those.
And so I suppose this is, you know, the why it needs a, you know, individualized one-on-one expertise to implement a mindfulness intervention with someone, rather than this idea of a population-wide intervention that's going to be a panacea.
Absolutely, and that's why that's why I founded the Mrcbt Institute in 2003 to begin with, very gently, very slowly. But then in a few years later, we were already training people around the world in a way that we get results.
Yeah, I've got a question here from Kathy, who asked, how many sessions would it typically take for someone to benefit from mindfulness?
Well, we did, as I said, not me in particular, but my colleagues and I published a paper just recently, just a few months ago, of Sally Francis' PhD over the last 6 years. So it's been taking a while to measure those things, but basically it's a transdiagnostic application of MICBT, Mindfulness-Integrated CBT. And essentially what she discovered was already within stage 1 of MICBT, the first 4 sessions, and these were 6 groups, right? The first 4 sessions already people benefited extremely well.
Wow.
4 sessions.
All right.
And that's my experience in one-on-one delivery here in my practice. 4 sessions.
And so I've got a question for you, perhaps the final question. On the mindfulness-based self-efficacy scale, Bruno, how do you score?
Well, I haven't done that for many years. I don't know. I should try again.
I give myself all of them, honestly. I mean, I think I'm on the 65th percentile overall on that scale. So
that's pretty good.
I'm doing okay, but you know, a bit more work to do. So
this way, if you score at the 99.9th percentile, I'd be worried, because
well, yeah, I'd be a liar
about it. Yeah.
Yeah, I'd be a total liar. And I think that you know, you've overcome some of the limitations of self-report mindfulness measures, but we've all got biases in the way we answer things anyway. So I think we'll finish up there. Dr. Bruno Cayoun, thank you so much for this presentation. And to the audience, I hope that you've found it helpful. I hope that you'll be able to think about how to systematically measure mindfulness in your practice, and some of the limitations of asking directly how mindful someone is, because chances are they might not know. So take care, everyone. Oh, and again, if you're not yet a NovaPsych user, there is a link that I'll put in the chat right now that will allow you to have access to that, so you can self-administer that scale, those scales, and see where you sit. So take care, everyone. Bye.
And thank you, Ben.